Masih jalan kok, Dok? Okay, good afternoon, ladies and gentlemen. Once again, welcome to our first webinar series. So, before we start, I want to greet all of the medical doctor. So, we broadcast this webinar. We broadcast this webinar in Jakarta. So we want to greet the participant in Philippines. We glad I glad to welcome you in this webinar, and also Myanmar also join. I heard also they will join this webinar, and then Cambodia, Sri Lanka, Singapore. So please welcome and thank you for your participation in this webinar. So a little brief about Calpi International, because this event we made a collaboration between Calpi International and also Calpi. So Calpi International is the largest pharmaceutical industry in Southeast Asia, and currently we are present in majority in Southeast Asian countries like Philippines, Vietnam, Cambodia, Myanmar, and so on, and of course Indonesia. And we also well established in West Africa, which is in Nigeria, and also Sri Lanka. So for today's topic, still related to COVID-19, because this topic is quite hot for now. So the topic is loss of smell as an early symptoms of COVID-19. What research is uncovering? So as you know, because all of you, I believe, as a medical doctor or healthcare professional, mostly COVID-19 symptoms related to fever, and then coughing, and then for the severe patient, they will get pneumonia. But one of the research from China, if I'm not mistaken, they mentioned that loss of smell also as an early symptoms of COVID-19. So today's our speaker, Dr. Lupita Wijaya, will explain everything related to loss of smell. So if you have any comment or you have any question related to the topic, you can give directly your comment in the section below, because in the YouTube you can find, while we are doing the live show, you can see the comment column, and then you can type in those sections. So at the end of the show, we will choose some of question, and then we will answer on based on your question. So basically, you don't need to wait until end of the show, but in the middle of the show or now, if you have any question, you can just put your question in the comment section. So without further ado, I will like to invite Dr. Lupita Wijaya, to present about loss of smell as an early symptoms of COVID-19. What research is uncovering? Just a little brief. This event supported by Brain Act, City College, the ideal brain plasticity boosters with high dose preparation. Time and screens for Dr. Lupita. Thank you.
Good afternoon, ladies and gentlemen. Thank you for joining our webinar today. Let me introduce myself first. My name is Lupita. I'm general practitioner from Jakarta or Indonesia. Today, we will discuss about our topic is loss of smell as an early symptoms of COVID-19. What research is uncovering? So, let's start the discuss first. There are several subtopics that we will discuss today. First is about what is COVID-19. Second, epidemiology of COVID-19. Third, symptoms of COVID-19. Fourth, comparison between COVID-19 positive and COVID-19 negative patient with smell impairment, and fifth, pathophysiology of anosmia in COVID-19. And the last topic is about studies about anosmia or hyposmia at several countries, include Wuhan, China. As we know, COVID-19 is the disease that caused by coronavirus or maybe novel coronavirus 19. Later name this virus we call as SARS-CoV-2. Coronavirus is an enveloped non-segmented single-stranded RNA virus with the size until 32 kilobases. You can see at the left side of the slide, there is the picture of this virus, which is you can see the virion inside her body, the orange one. This virion is composed of genome RNA and nucleocapsid protein. So what we should do? The drug therapy actually, we hope, or maybe clinicians hope the target of therapy in this virus is on this spike or S, the yellow one. Why? Because the spike protein is the site of binding virus into the host cell. And then, because of this virus has appearance like crown, we also call this virus like crown virus. With the organ target of this infection, there are three main of organ target. First, upper respiratory tract. Second, lower respiratory tract. And the last one, GI tract. So some patients will feel or maybe will have GI symptoms like diarrhea, constipation, and maybe abdominal discomfort. Why? Because in GI epithelial cells, there is ACE2 receptors. ACE2 receptor is the main cellular for the receptor of virus. So the virus will bind into this receptor and infect into the GI epithelial cells. Because of that, some patients will have GI symptoms. And then for the next, according to the study of viable virus, there are variants of median time for this virus survival. The median you can see on plastic, this virus will survive for 5 days. In aluminum, this virus will survive until 8 hours. And the last one, on the wood, this virus can survive until 4 days. You can imagine this virus how spread on several medians at various median times. And then we come into the infection stage of COVID-19. Actually, according to the study on April 2020, the virus when come into our body, the COVID-19 or maybe SARS-CoV-2 will have 2 stages of infection in human body. What is that? There are early stages and also severe stages. What is the difference between these stages? When the virus comes in our body, there is the immune response, initial immune response from our body. So actually, at early stage, we can give immunology therapy to induce or maybe to getting high the immune system in the patient body to eliminate this virus from our body. But if our body fail to respond or maybe to eliminate this virus, so the virus will enter to the severe stage. In the severe stage, the virus can induce the inflammation process that damages some organ, especially in our lung, because one of the targets from this virus is low respiratory tract. So what we can do for the severe stage, we can block the hyaluronidase, and the second one, we can block the synthase of HAS2 by one drug, the 4-MU, or we can call 4-methyl butyrophorone. And the last one, our body also can activate the messenger stem cell for reducing or maybe suppressing the inflammation because of this virus. And the last one, we can use when the patient start to begin cough, we can give vitamin B3. Vitamin B3 is one of vitamins that have highly lung protection. So we can protect the lung from the infection this virus with vitamin B3. And then before we come into the epidemiological data for this COVID-19 disease, we must know this pyramid figure. This pyramid figure divided into 3 levels: fatal, severe, or maybe mild. At mild level, patient will not seek healthcare because they feel their body is fine. But when the patient comes into the level severe or fatal, the patient may be seek healthcare and may be diagnosed and isolated for at least 14 days, maybe at home or maybe at hospitalized. We know that COVID-19 started in Wuhan, China at the end of 2019, and as of January 24, 2020, at least 830 cases have been diagnosed in 9 countries like China, Thailand, Japan, South Korea, until United States. But we cannot predict actually exactly how the percentage between these 3 levels. Why? Because we don't know yet exactly the proportion between the mild or asymptomatic case and the severe, or also with the fatal cases. Because to know this proportion, we need the epidemiological data that comes from the number of patients or the number of cases that happen around the world. But the number still most likely continue to change until all infected persons getting recovery. This is the temporary epidemiologic cases of COVID-19. Actually, we get from the World Health Organization that actually increase day by day. As of April, to 26 April, I have been updated. 26 April, you can see the data on the table. On the table, there is the global until African continent. You can see the increased new case that confirmed as COVID-19 positive. The biggest one is happened in America with the new cases about 47,000. So what is the difference between this kind of virus? There is 3 kinds of virus that may be get pandemic around the world. The first is SARS-CoV, the second MERS, the last one is the new one, SARS-CoV-2 or COVID-19 or maybe novel coronavirus 19. The difference is COVID-19 for the transmission, actually the main transmission is by respiratory droplets and then close contact with disease patient. But fecal, oral, and aerosol still under study. Some clinicians suspect that the possibility for the virus to be transmitted by fecal oral because that I have explained at the previous slide. At the GI epithelial cells, there are ACE2 receptors that bind it by this virus. And the second, for the latency, this virus actually 90% becomes symptomatic for several patients in between 11 until 14 days after the contact. And for the contagious period, COVID-19 is unknown because still under study right now. We don't know yet when the health patient bring the virus and then getting maybe and then infect the other people. We don't know yet when it's beginning. Maybe in 4 hours, maybe in 5 hours. So it's still unknown. And for the fatality rate for temporarily, because of it come from Hubei, China, the fatality rate is still around 2.3%, with the radiological figures, mainly at early stage, is ground glass opacity. And the last one, for the clinical presentation, most likely patient without comorbidity disease will not come into the severe stage. This is the three main of symptoms that we must be careful when we do early screening of COVID-19. First is fever. It's about 83 until 98%. The second is cough. It's about 59 until 82%, and the last one is shortness of breath. It's about 19 until 55%. But we don't forget, we must be careful. There are another symptoms like muscle aches, 11 until 44%. The second, hypoglycemia, or maybe we can call loss of taste, about 5.6%, and the last one, hyposmia, or maybe we can call loss of smell, or maybe smell impairment, about 5.1%. Besides the symptom, we must do some chest CT scan, or maybe some supportive assessment, like CT scan, or maybe laboratory, because we must be correlated with the main symptoms or maybe another symptoms that I have mentioned at previous slide. For the chest CT scan, actually at early stage, we found out the multiple ground glass opacity, maybe on single chest or maybe in bilateral lungs. And then, beside the multiple ground glass opacity, we can find the bilateral patchy shadowing, about 51.8%, until the red one is interstitial abnormality, about 4.4%. And for the laboratory, actually, usually in patients with COVID-19 positive, we can find the leukopenia or maybe lymphopenia. Because leukopenia or lymphopenia can describe there is the decrease of immunological response in human body to the virus. Because of that, we cannot rely on symptoms, clinical symptoms only, but we must relate with the other assessment like chest X-ray. In chest X-ray, when the severe stage, you can find the crazy one, the crazy paving pattern in both of lung. And for the diagnostic, to establish the exact diagnostic or maybe to support the COVID-19 diagnostic tool, actually the biggest one or the important thing is RT-PCR, or maybe we can say reverse transcriptase PCR to know the antigen of this virus. Or maybe we can do the first things at early stage is antibody test by IgM or ELISA test. Because correlation between these three things, between clinical symptoms and then laboratory figures, and then the last one about radiological figure, this is an essential need to establish or maybe to facilitate the early diagnosis of COVID-19 and several patients, because some patients will not will not always show the main of three symptoms that I have mentioned, like fever, cough, or maybe shortness of breath. Some patients will not show like asymptomatic, like health, or maybe like mild. But be careful in their body, maybe there is COVID-19. Be careful in the circle, you must remember maybe most of them, about 80%, this disease is mild. But be careful for the comorbidity patient, maybe actually 4.7% going into the critical one. What is the risk of factors that the patient will have COVID-19 later? Elderly, people with underlying disease like diabetes, hypertension, or maybe high cholesterol, and the last one, heart disease. Because from these three underlying diseases like diabetes, hypertension, or maybe cardiovascular risk, maybe influence or induce this patient about 10% to come to get infected by this virus. I get this percentage of the risk from the Wuhan, China data. And we know above 80 years old, there is a higher risk, about 14.8%. Besides three main symptoms, or maybe other symptoms, there are some neurological manifestation of COVID-19 that we get from the observational study at Wuhan, China, from January 16 until February 19, 2020. You can see there are two kinds of neurological symptoms. First, from central nervous system, and the last one from peripheral nervous system. As central nervous system, you can see the most symptoms that will happen into the patient is impaired consciousness. It's about 7% until 14%. And then for the peripheral nervous system, the patient most likely will have the smell impairment is about 11 until about 5 until 6%. And this is the consensus of COVID-19 for neurologicals. Actually, the incubation period for this virus is between 3 until 14 days, according to the immunological response in our body when the firstly contact to this virus. But Wuhan reported this incubation, or maybe this window period, can be extended until 24 days with the general symptoms that I have mentioned: fever, dry cough, and also difficulty breath. Because of that, we must be careful. The nervous system manifestation at the previous slide that will be significantly in patients with the severe infection, or maybe with the comorbidities one. And it will be manifested as ischemic stroke or maybe cerebral hemorrhage, because the high inflammation or maybe the ACE2 receptor will be induced the high of angiotensin 2. Because of that, the happen is the blood pressure will be getting high, and this is the risk to get the cerebral hemorrhage. More than 1/3 of patients will experience these various neurological symptoms. From central nervous will be dizziness, impaired consciousness until epilepsy. And for the peripheral nervous, the patient will have taste impairment until vision impairment. And because of the patient didn't have the better one immune response at early stage. So she will enter the severe stage and will get the inflammation storm because of the high of interleukin 6. And this storm will distract the lung, and also this virus will enter the blood into the blood to reach the brain by infect the intestinal cell, because intestinal cells actually we can say this is the second brain that connected to the brain by nervus vagus. Be careful, person who already cardiovascular risk factors could have his or her first attack. So, besides the dizziness, consciousness impairment, or maybe some epilepsy, don't forget at peripheral nerve system there will be smell impairment, or we can call anosmia, when the people cannot smell anymore. Anosmia, actually, this is not the focus of symptoms that we usually use at early screening. But because we dismiss these symptoms, we still under control to the diagnosis of COVID-19. We can see of the proportion of patients, 58% of patients actually get COVID-19 positive. COVID-19 positive, if we break down into two types, anosmia negative or maybe anosmia positive, we found a patient with COVID-19 positive, there is 68% that have anosmia. And for the patient without COVID-19 positive or maybe with COVID-19 negative, we found out 16% of these patients have anosmia. So we must be careful anosmia as one of main symptoms that we must care, or maybe we must pay attention when we do early screening diagnosis of COVID-19. Why anosmia can be happen because of this infection? You can see at the figure, at the nose of the human, there is olfactory epithelium. In this epithelium, there is nerve olfactories. And also in this epithelium, express the ACE2. You know that is the ACE2 is the main cellular immune that binded by this virus. Because of that, this virus, firstly, when the patient takes a breath of droplet, the virus will reach firstly at the olfactory epithelium and express the ACE2 or bind the ACE2. Because of that, it may make this patient have smell impairment or anosmia. What we can do at early screening diagnosis of COVID-19, USA by K et al. In her study, he made the reporting tool for anosmia. Actually, for the patient with COVID-19 or not. The patient actually can fill the blank by online. Just input the age of patient, the gender, and then the location, when the patient has been before, and then she put, is there any source, or maybe is there any people who contact with them? If there is a person that contact with them, she or he or the patient must feel when it started to contact until reach or maybe until have the anosmia firstly. And then the patient must feel what kind of risk factors that maybe they have a high risk to get infected by this virus. Maybe they ever been with the healthcare, or maybe have close contact with other people that confirm case COVID-19, or maybe they have been traveling to the pandemic area like USA, or maybe go to Malaysia and so on. And if they have comorbidity disease, they must feel what kind of disease they have. Maybe head trauma, allergy, or maybe chronic respiratory cardiac disease, or maybe they have Parkinson before, or maybe they have hypertension, diabetes, and also cardiovascular disease or stroke before. And then she must fill the blank when the anosmia happened firstly, before they know they have COVID-19, or maybe after they know they have COVID-19. Okay? Besides the anosmia, the doctors should know the patient feel this blank about what kind of symptoms they have besides anosmia. Maybe they have fever at firstly before anosmia, or maybe fever they have it after anosmia, and so on. After that, we should know the patient what the condition right now of the patient. Is it getting worse on number 12, or maybe getting improved? And the last one, they must fill the blank if they have received treatments like cough drug, or maybe they have another drugs like paracetamol. They must fill the blank or put the tick on number 15. And the last, if the patient has any other comments or maybe additional information, maybe they have sister with COVID-19, they must put here on number 17. Okay. And then for the last topic that we will discuss is about several studies of hyposmia or anosmia that happen in several countries, include Wuhan, China. This is the study that happened at Iran on March 2020. This is the cross-sectional study that shows the graphic one. This graphic is the age distribution between 7 until 78 years old patient, or maybe population of Iran. You can see at below that I have pointed. This is the race number, the patient, or how many people of Iran that get infected or maybe already confirmed as COVID-19 positive. It's between 100 until thousands. You can see what I have pointed. This is there is the correlation linear between to the incidence of hyposmia or anosmia to the population of Iran. Actually, at the same dot between 100 and 1,000. We can conclude there is the correlation between anosmia and COVID-19 positivity around population of Iran. If we can break down in detail, we can see in this graphic 17.3% of the population with anosmia in Iran cannot smell at all anything, with score 0. And only 7% of these patients in iron that still have normal smell function. So the big conclusion for the study is the onset of anosmia was sudden in 78.6.24%, and until right now 60% of patients still have the smell impairment constantly without the improvement to the better one. So we must take care for these symptoms. And the last about the study at Wuhan, compared to another country, we can see at Wuhan, the patient we only got the symptoms, smell loss, without fever, without cough, without shortness of breath, is about 5.1%. And the biggest one is happened in Europe, about 85.6%. Because of that, what we can do if there is the first attack ischemic stroke or maybe smell impairment in their nervous system, we can do supportive treatment. Actually, especially for the patient with first ischemic stroke, we can fix or support the neurological function with the citicoline, which is treatment oral at least 1000 milligram daily citicoline can improve the cognitive status until 2 years after the ischemic stroke. It's about 14.4%. And during the treatment, the citicoline will do two mechanisms for brain plasticity in ischemic stroke. First, for neuroprotection, we can use at least 2000 milligrams daily combination between injection and oral. And after 1 month, we can use only oral about at least 1000 milligrams daily of citicoline to continue the neural repair one until there is the increase of neurotransmitter or maybe neurogenesis. But actually, for the main therapy for COVID-19, is still in study. Thank you. If it is all about my presentation, thank you for the attention and participation. If you have any question, you can freely ask to me, or maybe you can give any feedback to us. Thank you.
Yeah, thank you very much, Dr. Peter, for the informative presentation. So I got already some comment and also question from the participant. So first comment is from Dr. Kiao Tu from Myanmar. I'm sorry if I made some wrong in pronunciation. So the first comment is loss of smell. If we loss of smell, we don't eat well. So that's the comment from Dr. Kwai Tu. And also GP syndrome can also be seen in COVID-19. So I will collect some of the comment and also question first before Dr. Lupita will answer that one. And the second question actually from Stanley Jayatilaka. I believe this gentleman comes from Sri Lanka. And the question is, what is the success rate of RT-PCR? What is the success rate of RT-PCR? And the next question from Fidusan from Sri Lanka, I believe. What is benefit of adding vitamin B12 or mecobalamin to treat this neurological manifestation? So maybe Dr. Lupita can answer these three questions first before we move to another question.
Sorry, Mr. Aditya, can you repeat the first question?
Okay, the first question is not a question actually, the comment from Dr. Kwaitu from Myanmar. If we have a loss of smell, so it means also the patient cannot eat well, right? I mean, the consumption of their daily food also will reduce. And the second common is a GP syndrome, can also be seen in COVID-19 patient. And that's the first comment. So any input, Dr. Lupita?
Okay. Thank you for the questions. I will answer the first question is how the success rate of RT-PCR in COVID-19 diagnosis. Actually, according to the journal 2020, Link say that the RT-PCR we can do with the sensitivity about 71%, with the specificity almost 100%. So when the patient get RT-PCR assessment and we get the result is negative, we cannot exclude this patient is free from the COVID-19. Besides, the patient have suspected symptoms like fever or maybe cough or maybe close contact with the other patient that confirmed COVID-19. But we must do the isolation first. And then after several days, we must check again with RT-PCR. Because once RT-PCR get the result is positive, linear with the specificity 100%, we can conclude this patient as COVID-19 positive.
Okay, so the success rate more than 70%, correct, Dr. Lupita?
What?
So the success rate for RT-PCR is more than 70%, right?
Yes, we can say that from the start.
So because I'm also curious about this one, still related to the diagnosis tool. If let's say if the patient already 70%, the success rate from PCR is almost 70%. Do we need still do like a CT scan to really determine this patient really positive COVID-19? Do we need to combine also, or I mean stop in PCR? That's it. We can.
Okay, actually, I want to explain first the success rate of CT scan. If we do chest CT scan, the sensitivity is almost 98% from the study at Wuhan. And then, but unfortunately, we can do at early stage because at early stage, 4 until 50% is normal figure. So we can do at early stage is RT-PCR from the 3rd days after the symptoms appear. And CT scan we can do to evaluate the condition of the patient after a week. That's all. So we can do the CT scan or not if the patient is asymptomatic or maybe negative PCR or maybe they have do the therapy and we want to evaluate later days after we do the intervention.
Okay, noted. Thank you for the, because I'm quite curious also for this question. And then the third question about the benefit of adding vitamin B12, Dr. Lupita. Vitamin B.
Thank you for the question. We know that from the journal that explain about the immune role and several vitamins show that vitamin B12 has 3 actions. First actions from the innate immune system, the first one, This immune system is non-specific and fast in several days after contact, in hours until days. The vitamin B12 can increase or support the natural killer function to defense to all antigens, include the microorganisms like virus, bacteria, and so on.
Okay.
And the second action, vitamin B12 on adaptive immune system later on, or maybe specific one, after a week until 2 weeks getting infection or contact, the vitamin B12 can increase as immunomodulator to increase the production of lymphocyte T or T cells to recognize specifically the virus. And the second, she will increase the synthesis of B cell or lymphocyte B to produce the antibody for human body. And the third action, this vitamin B12 can suppress the inflammation process, specifically suppress the TNF alpha, that one of mediator inflammation that can make the lung getting into the worst inflammation. That's all, Mr. Aditya.
Wow, so many benefit, right, from the vitamin B12. I think vitamin B12 can be another option besides vitamin C, right, Dr. Lupita?
Yeah, actually can support, but
And
not
support.
but not the first
Yeah.
therapy for COVID-19. Actually.
Yeah. Okay. So, and also I received already another two question. The first question is how COVID-19 infection could induce stroke incidence in patients with comorbidity disease. And the second question is there anything you can do at home to test or to see if you are suffering a loss of smell? That's the next question.
Okay, thank you for the question. I will answer first. How can this COVID-19 infection can make the stroke attack for the patient with comorbidity disease like diabetes or maybe hypertension? Because I want to explain the basic one. We know the ACE2. ACE2 receptors is the main cellular function that bind it to the SARS-CoV-2 or COVID-19 virus. Actually, at Wuhan study by Maulin 2020, we realized in this study that mentioned these ACE2 receptors not only at GI epithelial cell, but also at several organs like lungs, renal, nervous systems, and also cardio. Because of that, in study explained that the clinician, there is the hypothesis about the mechanism stroke attack. The COVID-19 or SARS-CoV-2 suspected to infect this ACE2 receptor on nervous system and then induce the increase of angiotensin II level in nerve, especially in blood circulation of the brain. After that, what happened? The blood pressure getting high, or maybe not getting high, just distract the blood vessel. Because of that, there is the high risk to get ischemic stroke or maybe hemorrhagic stroke. Okay. And then for the next question, how we can do at home to know that we have, or maybe we already have sudden hyposmia or smell impairment. We can do simple things. We must close our eyes. We prepare first the substance that we want to smell. We call it as odor test identification. We can use coffee, tea, or maybe in study we can use garlic. After we prepare the substance and close our eyes like blind people, we close one one side of nose. Maybe we can start from the right one to close, and then the left one can try to smell what kind of substance that I have been smelled by my left side of nose. This is true. This is tea or coffee, or maybe this is garlic. And then repeat for the other side. If we wrong answer the substance, we must be careful that we maybe already have the early smell impairment. Okay, that's all about my answer.
Okay, thank you, doctor. The last question, Dr. Lupita, from Dr. Salome Dicamco, I believe from Philippines. Was there any new study if all this varying degree of loss of smell was recovered? And if so, when or how soon after being COVID negative?
Actually, for the low smell, until now, what we can do for the diagnose is only do the simple things like I mentioned before at home, or maybe we can do to fill the blank at the anosmia reporting tool that has been studied in USA by Kay and friends at early of April 2020. And then besides that, how can we know when it's recovered after the COVID-19 the end? We still don't know yet because this is still during under study. And until now, from the island population, the patient that already have anosmia or hyposmia has not been recovered, and this is happen constantly. So we must do the study further for the better therapy or drugs for these cases, or maybe for this anosmia. Okay, Mr. Aditya.
Okay, thank you, Dr. Lupita, for the question. So, I believe that last question from Dr. Salome Dijamko will be the last of our last session of our webinar series. So once again, thank you very much, Dr. Lupita, for your clear information, and also the participant, doctor from Philippines, Sri Lanka, Cambodia, and of course from Indonesia. We are very we want to say thank you because of your active participation. So before I end this webinar, I want to inform you also that we will have another series, webinar series. We will live. Later, we will inform either in YouTube or in Zoom. The topic is pathophysiology of decreased immune system of CKD patient. The webinar series will be held on May 9 at 12 p.m. Jakarta time. So for the detail, our medical representative will inform you, all of you, about this webinar series. And of course, don't forget to visit our website, www.calpmed.com. Once again, www.calpmed.com to get the further information about webinar series. And also don't forget to subscribe our YouTube channel, CalPmed. So in the future, you can also watch the another webinar series. And all the last one is, if you want to download the video of today's webinar, you can visit once again CalPmed on YouTube, and you can download or you can relook again the material on CalPmed channel on YouTube. So once again, on behalf of Calpe International and also CalPmed, I would like to say thank you and see you on the next webinar series. Thank you.